Hello and welcome to the topic Approach to Acute Abdomen in the surgical module. By the end of this session, you should be able to define acute abdomen, explain the pathophysiology of acute abdomen, identify causes of acute abdomen, recognize associated signs, and discuss the principles of management of acute abdomen. First, let's look at what is the definition of an acute abdomen. The acute abdomen is defined as a sudden onset of severe abdominal pain developing over a short period of time. The initial assessment should attempt to determine if the patient has an acute surgical problem that requires immediate and prompt surgical intervention or urgent medical therapy. Acute abdomen is divided into two groups, which are those presentations that need urgent intervention and presentations that are less acute. The ones that need urgent attention include bleeding, perforated viscous, and ischemic bowel. The less acute ones include colic and peritonism. Let's look at bleeding. The most serious cause of intra-abdominal bleeding is often the ruptured abdominal aortic aneurysm, which requires swift referral to the vascular team and immediate surgical intervention. Other common causes usually involve a slower rate of bleeding, but the urgent surgery will be still required. These include ruptured ectopic pregnancy, bleeding gastric ulcer, and trauma. Peritonitis is the inflammation of the peritoneum, and generalized peritonitis is most commonly caused by the perforation of an abdominal viscus. The causes of perforation are broad but include peptic ulceration, small or large bowel obstruction, diverticular disease, and inflammatory bowel disease. Patients with a generalized peritonitis present with often lay completely still, not able to move their abdomen, and they look unwell. This is especially important when compared to a renal colic, whereby patients are constantly moving and cannot get comfortable. On examination, they will show signs of tachycardia and potential hypotension, a completely rigid abdomen with percussion tenderness, involuntary guarding, whereby the patient involuntarily tenses their abdominal muscles when you palpate the abdomen, and finally, reduced or absent bowel sounds, which suggest the presence of a paralytic ileus. Any patient who has severe pain out of proportion to the clinical signs has ischemic bowel until proven otherwise. They are often acidemic with a raised lactate and physiologically compromised. Patients will often complain of a diffuse and constant pain. However, the examination can often otherwise be unremarkable. Definitive diagnosis is via a CT scan with intravenous contrast and early surgical involvement. Presentations that are less acute are as follows. Colic, which is an abdominal pain that crescendos to become very severe and then goes away completely. The most common types of colic are seen in biliary colic, ureteric colic, and bowel obstruction. Next is peritonism, which is less acute. Peritonism is not peritonitis. It refers to the localized inflamed peritoneum, usually due to inflammation of the viscus that then irritates the visceral peritoneum. This leads to patients stating that their abdominal pain starts in one place, which is irritation of the visceral peritoneum, before localizing to another when there is an irritation of the parietal peritoneum and then becoming generalized. The classic example of this is acute appendicitis, with the pain migrating from the umbilical region to the right iliac fossa, and this causes inflammation of the viscus. That then leads to irritation of the visceral peritoneum, inflammation of the peritoneum itself in general, and then this gives rise to peritonism, which is characterized by abdominal pain. There are a lot of differential diagnoses we can make over the abdomen area, thus, your history taking and physical exams are very important. The location of the abdominal pain is one useful feature that helps narrow the differential. These can be classified based upon quadrant or region affected. It must be remembered to always consider extra abdominal organs as the cause for abdominal pain, including cardiac, respiratory, and gynecological or testicular conditions. For bedside examination, it's important to examine the abdomen to identify potential masses, wounds, or presence of distension. Lab investigations are useful to help you clinch the diagnosis. Urine dipstick is done. If there's presence of renal tract infection, it may indicate a presence of leukocytes or nitrites. Pregnancy tests may exclude pregnancy in the event you suspect ectopic pregnancy. An arterial blood gas is important to pick up hyperacidemia or hyperlactatemia. Other blood tests that can be done include a full blood count, renal profile, and liver function tests, blood cultures, as well as group safe and whole or group cross match. Other imaging studies that can be done include a chest x ray, which will be useful in picking up a possibility of perforated viscus. CT scans and ultrasounds, which are more localized and defined in identifying potential masses, obstruction, or perforation. Now, we have already come to the management part. The definitive management of acute abdomen largely depends on the cause. However, a good initial management includes core points regardless of the underlying etiology, and these include setting large bore brannulas for resuscitation, keeping the patient nil by mouth, starting intravenous drips accordingly, preparing group safe and whole or group cross match if bleeding is suspected, or if the patient might go in for a surgery, providing them regular analgesia, putting on a urinary catheter if indicated to monitor fluid balance or patients unable to pass urine, and inserting a nasogastric tube if an intestinal obstruction is suspected or if the patient has a distended abdomen. In the surgical department, you must always have a mindset that the patient will be pushed for a surgery anytime. Thus, pre-operative preparation is very important. In summary, acute abdomen is a condition in which sudden abdominal pain occurs and signals the need for immediate attention. It is important to identify the urgent causes, for instance, bleeding, perforated viscus, and ischemic bowel, before the organ or tissue becomes non viable and be detrimental to the patient. Send off important markers to assist with the diagnosis. Imaging studies are equally helpful in excluding sinister causes of acute abdominal pain, such as perforated viscus. And management begins with initial resuscitation, ensuring the airway is protected and the circulatory volume is adequate to prevent shock or organ hypoperfusion. Patients should be advised to be nil by mouth to anticipate surgery at any moment. Diagnosis is best established through imaging studies as non invasive methods are used to identify the source of the problem. In difficult cases, surgeons may need to explore intra-abdominally to identify the source. So we have come to the end of this topic. We hope it was insightful and thank you for your time.